Hi, on behalf of the Association for Vascular Access and the I Save That webinar series, I'd like to welcome you to tonight's webinar, The Evolution of ECG with Centrally Inserted Central Catheters. I'm Blake Hotchkiss in the AVA Education Department. Joined with me today is Judy Thompson, Director of Clinical Education, and Tim Spencer, our speaker for tonight's presentation. Moving right along, so I Save That webinar. It's time for the show. So our very own Tim Spencer. So there's the bio for you to read, but let's fill in a few blanks on our presenter today. Let's go back a few decades. So in 1996, Tim established the Central Vascular Access and Parenteral Nutrition Service at Liverpool Hospital in Australia, which he led until 2014 when he moved to America. During his tenure at the Liverpool Hospital, he pioneered the role of the Advanced Vascular Access Specialist in Australia, which enabled his team to place the most appropriate device for the patient, their condition, and of course, their clinical history. Tim is the author of numerous publications in peer-reviewed journals for vascular access practice, advancement of practice, and advanced technology. He also volunteers his time to work with first-time authors as they maneuver the process of publication. Tim also serves on editorial review boards for multiple peer-reviewed and evidence-based journals. In earlier years, Tim served as a director-at-large for the Vascular Access Certification Corporation, or VAC, and was the first Australian clinician to be Vascular Access Board certified in 2014. Tim was honored last year as the recipient of the 2019 Suzanne LeVere Herbst Award for Excellence in Vascular Access from the Association of Vascular Access. Tim is one half of the dynamic vascular access duo with Amy Barden Spencer, who is also a recipient of the Suzanne Herbst Award and also a previous speaker on our webinar series. He is an avid historian, wine connoisseur, and a guitarist. Without further ado, allow me to present the multi-talented Tim Spencer.
Thank you very much, Blake and Judy. And I'll just share my screen so that we can bring up our presentation. Just make sure everybody can see that. All good?
All good. Take it away.
Excellent. Okay. Well, welcome everybody, or should I say good morning, good afternoon, or good evening for wherever you are around the world. But I do thank you for joining all of us here today for today's AVA webinar. Today's topic will be the evolution of ECG with CICCs. Oops. Let me just click on the screen. Just a disclosure, although Blake did run my bio very nicely, I also work for Teleflex. I'm the Global Clinical Marketing Manager for the Vascular Business Unit. So just like any regular educational component, we always have to have a set of objectives that we want to achieve throughout the course of the session. And these objectives are listed here on the screen. So we're going to review intracavitary ECG for centrally inserted central catheter tip positioning. We're going to describe the importance of the tip location accuracy. We're going to review some workflow and financial benefits around ECG confirmation, and also discuss some of the safety benefits that ECG provides when we insert CVCs. Okay, so as Blake mentioned, I'm a little bit of a history buff, and from an ECG perspective, we can look back at a little bit of history. And this slide really just gives a very brief but early timeline picture of what actually happened when people started investigating our electrical conductivity of the heart. And it was first performed by Augustus Waller in 1887, where he used a capillary electrometer to actually look at the first ECG rhythm in humans. A few years later, or almost a decade later, William Einthoven actually investigated the electrical waveforms as well and took on Waller's further research further, and eventually came up with what we see today as the P, Q, R, S, and T waves. So really, since 1895, the nomenclature and the fundamentals of our electrical conductivity of our heart haven't changed. Herman Hellerstein, we jump ahead to 1947, so just in the post-World War II period, was one of the first physicians to monitor the heart's electrical action at the distal catheter tip using a column of saline method. So one of the regional uses of ECG from a historical perspective, where in the world is it being used? Well, it's being used quite widely in a number of different countries, and that was one of the things that we wanted to look at. Now, I can't see my slide notes in this presentation, but anyway, we have a poll question.
Looks like time for the poll.
Yeah. Blake, how do I see my slide notes?
Oh, that's a good question.
You have to be in presentation mode. I think y'all have to have 2 monitors up, Tim.
Oh, thank you.
Oh.
Say bollocks.
Hang on.
Well, as Tim's playing with that, let's shoot off those polls.
Let's do that. So let's launch this one. This is our foundational question. Which devices have you used for tip confirmation technology, or have you used it on? You got the PIC, you've got central lines like 6, HD caths, or none. You've never used ECG tip confirmation. Share the results. PICs obviously took the cake here, the lead, 83%. Central inserted central catheters, 8%. HD was 4%, and none was 16%.
So we had a question as well as, I think we'll add another one coming up, and that's gonna be the impromptu one, as who uses it in pediatrics. So I'm gonna go fill that in on the back end here, and then we'll launch that one again too, because I'm really curious to find out who uses this in the pediatric setting. So hold on, that one's coming.
How long does it typically take to clear a central venous access device for use in your hospital?
1 hour is the majority at 208 or 75%. So it takes about an hour to clear one. And then 21% say it's 2 to 4 hours, and then a whopping 10% greater than 4 hours. That's a long time to start to wait for a line to get cleared.
Right, so if we look at the evolution of tip location, we can see a couple of images here on the screen, and certainly on the left-hand side, we have a chest x-ray. Everybody's familiar with this, and you can actually see the line drawings of the outline of the heart and a number of the vessels. For many years, this has been the gold standard to check catheter tip position, and it's still used very widely in clinical practice today to determine catheter tip position. But certainly with the advent of newer technologies, particularly the ability to be able to connect and monitor intercavitary ECG, we can now be able to connect up to dedicated ECG monitors with the use of either a Guidewire or an ECG connector to be able to monitor our intercavitary ECG and monitor that during the insertion process. So what are some of the current tip confirmation methods? Well, currently there's really only 4: fluoroscopy, chest x-ray, ultrasound, and intercavitary ECG. Fluoroscopy being a rather more expensive option, exposes the patient to higher amounts of radiation, requires patient transport. You know, there's a number of resources that come into play that are utilized to perform the use of this technique when we're looking at tip confirmation. Chest radiography is essentially quite similar, whether it's done as a mobile procedure or done in the department itself. It requires an amount of transport and time, so it's not as necessarily time efficient, particularly when you've placed a device that you need to use fairly quickly. There's a lot more proponent of the use of ultrasound to now verify our catheter tip position. There's a lot of clinicians that are using this, particularly in emergency medicine and other areas of critical care. And then you have intercavitary ECG or electrocardiography. And certainly the last two being ultrasound and intercavitary ECG, there's no radiation exposure to the patients at all using these two technologies. So there's a great ability to be able to reduce any ionization radiation exposure to the patients that are unnecessary, particularly if they're having frequent chest x-rays. So this table really essentially looks at a variety of different components when we look at the differences between chest x-ray, ECG, and ultrasound. So I'm going to go through these fairly briefly, but you know, X-ray is still currently the accepted gold standard. And while that is still, you know, generally the case today, we are seeing a lot more evidence-based standards being developed around the use of ECG and ultrasound. So ECG tend to fall under more evidence-based standards, whereas the chest X-ray is the currently accepted standard. I think in a number of years, we will actually see that ECG and ultrasound combined may become the new accepted standard when it comes to device tip verification and confirmation. The use of chest X-ray does increase the delayed time for tip confirmation and delays in the use of the catheter, which I mentioned earlier. ECG and ultrasound, when combined, provide immediate tip confirmation that the catheter's tip is in the correct place, and there are no delays in clearance of the line for its use. Chest X-ray performs more of a generalized tip location as opposed to the accuracy with ECG and ultrasound once again combined. Pneumothorax can be ruled out obviously with a chest X-ray, as it can be done with a chest X-ray. However, ECG is only looking at the electrical conductivity of the heart, so it doesn't really rule out pneumothorax. But when combined ECG with ultrasound, that gives us the ability to be able to rule out intraprocedural and postprocedural pneumothorax. And doing a patient assessment, if you're using a receiver, prior to inserting the device, you're actually ruling out any pre-procedural pneumothorax or you know, faults with the pleural function prior to the procedure as well. So the benefit of added ultrasound is a very important aspect. With the chest X-ray, the accuracy of tip location is perceived, meaning that if I gave the same X-ray to 5 different people, they all might read it a little bit differently and report that the tip is in a various number of positions. ECG and ultrasound also accurately identify tip location. So we know that once these two are combined as well, they're going to provide a much more degree of accuracy in regards to catheter tip position as opposed to a chest X-ray. The sensitivity and specificity around chest X-ray is around about 65 to 68%, whereas ultrasound and ECG have much higher degrees of sensitivity and specificity, greatly above 95%. So there's, you know, this table really sort of highlights a lot of the differences between the 3 different techniques and how when we combine ECG with ultrasound, how much more superior it is to actually a chest X-ray. So what's the clinical importance of accurate tip position? So we're just going to have another poll question now. So I'm going to hand this back to Blake.
Do you currently use ECG for CVAD tip confirmation? Yes or no?
66% saying you do, and 34% are not at this point.
Okay, so why is tip position important? Well, that's a discussion in its own, but to really focus on a couple of things is that we all know that there's a lot of evidence around why catheter tip should be in the distal SVC or at the cavoatrial junction. And the image on the right-hand side really does highlight a lot of the thrombotic risk associated with malpositioned catheters. So if we have a catheter tip that's sitting in the brachiocephalic veins, the risk or the incidence of catheter-related thrombosis in the vessels is greater than 60%. It's relatively pretty high. As we move, you know, further down the SVC into the proximal SVC, we're looking at rates of around 42%. The mid SVC, it tends to drop down a little bit and it, you know, gets much lower as we get down to the lower 1/3 in the cavoatrial junction, certainly below 2.6%. Interestingly, the right atrium has a 0% risk, but we rarely put, you know, acute CVCs, you know, into the right atrium. there are guidelines around the recommendations for catheter tip position in the right atrium, which primarily comes around long-term hemodialysis catheters just entering the right atrium. But there are a number of guidelines and recommendations that are made by professional organisations. We'll see this in slides that are coming up soon, where they actually do recommend entry into the right atrium for certain conditions. So thrombosis, up to 16 times greater risk of thrombosis if the catheter tip is not in the right place. And that could be from a number of reasons. It could be because the catheter was not placed in far enough, or the catheter was actually too short to begin with for the patient's BMI or the insertion side to actually get around to the right to the right place. There's an increased risk of infection in the relationship with thrombosis. We know that there is now a bidirectional relationship that's been established between infection and thrombosis and vice versa. So, patients that are predisposed to higher rates of thrombosis are also predisposed to greater rates of infection as well. There's a higher occlusive rate or occlusion rate with the device and a loss of catheter function. That's problematic in its own right because it leads to further use of thrombolytic agents, which come at a cost in its own right, as well as the time delays in the patient's treatment. And that loss of device function impacts further down the pathway of patients' treatment protocols and regimes. There's a 62% malposition when the catheter tip is sitting in the proximal SVC, as opposed to 14% or lower when the catheter is sitting in the distal SVC when the catheter is power injected. So certainly a much higher degree if the catheter tip is too high and it's being used for power injection, that the catheter will actually malposition due to the power injection process. So ensuring that the catheter is down deep into the lower third will help prevent any unwanted malposition of catheters during power injection procedures. Wall vessel injury or perforation. Well, if we look at the image here and we're coming in from the left and we're thinking that we're going to place a 20 centimeter dialysis catheter, it's probably not going to be long enough to get round the corner and down into the lower SVC. So quite often, and I'm sure many of you have seen chest x-rays where there have been catheters that have been approaching the proximal SVC from the left through the left brachiocephalic vein, and basically it sits up against the wall like this. Well, that causes intimal damage to the proximal SVC, and that wall injury can lead to thrombosis, obviously, but it also can lead to perforation or rupture of the vessel wall, depending on the stiffness and the acuteness of the angle of the catheter. So catheters left in place unnecessarily obviously need to be repositioned as quickly as possible. Right atrial thrombus has been documented in the evidence. It's a rather rare complication associated with catheter tip position, but it's still been reported. So just another consideration that needs to be taken into fact when we're looking at the complications around catheter tip position. And lastly, cardiac arrhythmia. Cardiac arrhythmia caused from a number of different reasons, might be the guidewire, but a catheter that's entering into the right atrium because it's being placed too deeply. So there's a number of reasons why patients may get cardiac arrhythmia. I'm not going to go through all of them, but it's certainly documented that malpositioned catheters can actually cause arrhythmia as well. So this slide, tip navigation or tip location, Mauro Pittarudi, who we all know very well, who is a great voice for intercavitary ECG, once described navigation and location as two different things, and they are essentially two different aspects of central venous catheter insertion. And navigation really does highlight that it's used during the procedure to help direct the clinician or the operator to get the catheter or the guide wire to pass along the pathway that they've chosen to the right location, whereas catheter tip location is a method that's used really to just verify optimal tip position. And they both complement each other. And as you could see from the poll results, many of you are using navigation and tip location methods for the insertion of PICCs. This can be paralleled, obviously, with CBCs or CICCs, as we're calling them these days. And so there's a lot of benefit of the use of navigation and tip location. Although with most central venous catheters, the navigation aspect is not required as much because the catheters take a shorter pathway to get to their final destination. But still very useful tools, as we know in clinical practice. And, you know, optimizing our tip location really should be a mandatory process for all clinicians that are inserting centrally inserted central catheters. So a couple of the methods that we've sort of described at the moment can be categorized into really two different areas, and that is intraprocedural and postprocedural. And so some of the methods that I'm just going to briefly discuss here, obviously intercavitary ECG, fluoroscopy, and, you know, echocardiography techniques can be used intraprocedurally. Particularly with echocardiography, we're looking at transthoracic or transesophageal. In the post-procedural phase, this is where X-ray has had its greatest usage, but also the use of computerized tomography or CT scanning and magnetic resonance imaging and angiography. These are also other areas in the post-procedural phase of device insertion where you know, imaging is allowed and being able to verify catheter tip positions just as equally. Echocardiography, particularly transthoracic echo, can be used in the post-procedural environment, particularly amongst critical care where, you know, patients are having transthoracic echoes performed at the bedside and monitoring of the central catheter's tip can be seen relatively easy in a substernal view. Intercavitary ECG is recommended by a number of professional bodies because the technology for identifying tip location has proven to be time-saving, safe, and easy to perform. You know, these are very important points. So when we look at intraprocedural ECG, we should really be optimizing this during the procedure rather than after the procedure, because post-procedural control of tip location is associated with possible repositioning of the catheter tip, especially if it's been malpositioned during the initial insertion phase. And if that's the case, this implies that there's an increased amount of time to correct the malposition, there's an increase in resource uses, and it also the potential harm to the patient. Now, whether that's sending the patient down to fluoroscopy to have it repositioned under fluoro, or doing a guidewire exchange, or using a different technique to, you know, reposition the catheter, even a high flow flush technique, it all adds time and additional resources in its use to try and correct that catheter and get it into the right place. When we utilize intercavitary ECG intraprocedurally, we can see that if there is any potential for malposition, we can correct that intraprocedurally, as we may do in PICS, and that can sort of avoid a lot of the malposition tips that may occur. So what about some of the clinical guidelines and standards? What do they say around about tip location and the use of ECG? So there's a number of position statements from professional organisations. This is certainly a few. There's about, I think there's 19 or 20 or so professional bodies that are listed here on the screen that actually make recommendations around about where the catheter tip location should be positioned, but also in conjunction with the use of intercavitary ECG. This promotes, well, these organisations promote this technique around the globe. And as you can see, that there's a lot of international organisations. There's quite a few here from the United States, but there's a number from around the world where they have position statements regarding the use of ECG to guide CVC tip positioning. When we look at the breakdown when it comes to the recommendation of tip positioning and also the use of ECG, we can see that some of the guidelines going back as far as 2009, there are some that go back even earlier, but they haven't been included here. So between 2009 and even up until the recent updates with the KDOQI guidelines in 2020, there is recommendations around the final tip location for central venous catheters. And as I mentioned earlier, when we had the picture of the heart up with the thrombosis risks, and we talked about catheter tip sitting in the right atrium, this is where we're seeing a number of the recommendations stating that a catheter tip in the superior vena cava at the cavo-atrial junction or entering the upper right atrium is part of their standards or guidelines. So there's a number of them that actually mention this, and as you can see, many of these society guidelines and recommendations are relatively similar in their recommendations based upon the literature. When we look at the ECG on the side, many of them are saying yes, but there's several that are not addressed or have not made any recommendations as yet. But that's up to today's standards. So as we move forward into the future, this may possibly change, particularly with the increase in the amount of evidence that's being published around the use of ECG to place central venous devices. Some of the clinical attributes of intercavitary ECG and the benefits that it provides, particularly when we look at the function of different clinicians and hospital staff, administrators around a facility, we can break down their primary roles. And this table sort of really highlights the importance from being from very important down to low levels of important across a variety of different attributes, namely being accuracy, ease of use, the speed of the procedure. And as you can see, if we look here and we say operations looking at infection prevention, they get a light blue cell in the table, meaning that it's not of great importance for them as far as speed of procedure because they're not involved in the procedure. But the dark blue, on the other hand, gets across all for degree of accuracy, infection reduction, and then a darker blue or a slightly lighter blue, I should say, amongst the ICU vascular access and CRNA clinicians when it comes to ease of use. So this gives an overall sort of identification of where the areas in facilities will see benefits of the use of ECG to position CVCs, but also to be able to speak to those who may not be directly involved in the procedure, but it still has a lot of clinical relevance for the facility's resource utilization, etc. So the table is quite handy. And then you see, obviously, there's cost on the end as well. So one of the things that everybody's involved in, if you look, it falls under operation and department heads. Quite often, the leaders in these areas are very interested in what the bottom dollar costs are around the use of this technology. And this sort of gives us a nice overview of where some of those responsibilities may lie. So I've got to scratch my nose, it's itchy. Okie doke. We have time for another poll question. So welcome to the South Pole, everybody.
I love the pictures on these. Have you eliminated chest X-ray if using ECG for CVAD confirmation? We need to have a Jeopardy song timer in the background. So 61% have eliminated, 24% are using it without elimination. Another 14% are working on it, and 1%, so 3 of the people that have answered have tried and failed.
Right, so let's look at intercavitary ECG for the use with CICCs. So this diagram really gives us an overall view of the P-wave changes that are seen during catheter placement. Whether it's really with a PIC or a CVC, it's no different because it's looking at the electrical conductivity of the heart. So with the image on the left, we can see the picture of the heart. The catheter is in the proximal SVC, and then we can see a relatively normal P wave on our electrocardiogram image above the heart. As we move further down towards the cavo-atrial junction, we start to see a maximal peaked P wave. And as you can see in that image, it's almost the same size as the QRS complex. Once we just enter the right atrium, we'll start to see an initial negative P wave deflection. And you can see that small negative deflection dropping below the isoelectric line. And as we move further into the mid-right atrium, that negative deflection gets larger. Once we pass the SA node and are slightly deeper into the right atrium, we get a much larger negative deflection, as you can see in the ECG trace above. Now, these are all very important visual cues for clinicians to determine that the catheter tip position, sorry, I should say, is actually down at the SA node, because that tells us that we actually want to get the catheter down towards or slightly past the SA node so that we know that we've reached the correct position before we have to retract the catheter until we pull it back and get maximum P wave. So we would go through this process during the insertion phase. We would get to the end point, which would be our negative deflection, and then we would pull our catheter back very gently and slowly until we achieved maximum P wave. And that's going to tell us that our catheter tip is going to be at the cavo-atrial junction. So that's really essentially going through the stages of the P wave monitoring and looking at the changes in its morphology to determine where our catheter tip position will be relative to the SA node. Now this video I'm going to play, and let me just click on it. And this is really just a simulation of the catheter being advanced through the central venous circulation. And as you can see, we're being passed through into the subclavian vein. And if you look at the simulation of the ECG screen, the P wave is still normal. So the catheter, as it's being advanced around the corner, we're still in the subclavian vein, and now we've hit the junction where the internal jugular meets, and we're in the brachiocephalic vein. We're going to notice that the P wave amplitude is starting to rise. It's getting a little larger, and as we advance the catheter, a little bit further, that P wave is going to start to increase in amplitude. Moving down closer towards the cavo-atrial junction, the P wave has started to become peaked. And as we get closer to the entrance of the right atrium, we start to see that small negative deflection. And that's telling us that we're just on probably the SA node, but we want to really move that past it. And that's where our larger negative deflection that we're sort of moving to here in this simulation picture is actually showing. So the catheter being advanced, we've still got a biphasic P wave at the moment with a large amount of it in the negative. And now we see it drop down to get a large negative deflection, which really confirms that we've actually passed the SA node. This is an important strategy that we have to achieve before we retract the catheter back and get our maximum P wave, because this confirms that we've actually gone past the SA node. And that's part of the confirmation process that needs to be achieved during the process. Now, as you can see, the catheter is retracted. We have a maximum peaked P wave. It's almost the size of the QRS complex. And we can see that now we can confirm that the catheter is in the correct position. Oh, hang on. So how does it work? What are the methods that we have available to us to be able to provide intercavitary ECG? Well, there's two different methods that are available. There's a Guidewire method, and we have a column of saline method. Now, if you are using ECG in your clinical practice today, you may use either one of these. They both will provide the same outcome, and that's accuracy and safety about using intercavitary ECG. But the technique is just going to be a little bit different, and there's a slightly different amount of equipment that's going to be used to actually place these. So the Guidewire method uses the existing Guidewire that is included with the CBC kit, and is quite often used with a alligator clip or an ECG clip to attach onto the cable to create the electrical conductivity circuit. And so we can monitor P wave amplitude through the actual Guidewire itself. The column of saline method, on the other hand, uses the lumen of the catheter. The distal lumen is filled with saline, and an ECG adapter is attached onto the distal end of the catheters, or attached onto the hub of the catheter's lumens, and a continuous column of saline creates the conductivity channel. And so then an ECG clip or an alligator clip is connected onto that adapter, and that maintains the conductivity of the electrical signal as well. So the Guidewire method, I'm just going to go through the Guidewire method. Now, one of the important things about the Guidewire method, and I've got some equipment here on my desk that I'm going to hold up in a minute to show you, One of the most important things about using the Guidewire method is that you need to accurately measure your guide wire. And we all know that different catheters will have different length guide wires that are included in their trays. But the most important aspect is that when we do measure the guide wire, we need to measure it so that we can accurately retract the wire into the end of the catheter to put the ECG or alligator clip on in the right place. So we need to measure the catheter. So I'm just going to hold up this catheter and a guide wire. So hopefully you'll all be able to see this. So here's our catheter here. You can see the distal lumen here. Now the unused lumens would be flushed with saline and clamp because they're not going to be used. We're going to use the distal lumen. Now on all catheters, even though they look, certainly for this brand catheter, the Arrow catheter, all these lumen extensions are exactly the same length. So when we're measuring the guide wire, we need to add an additional 10 centimeters of length for the guide wire measurement to the catheter length. So depending on the length of the catheter, that will change, whether you use a 16 centimeter, 20 centimeter, 24 centimeter, 25 centimeter, 30 centimeter or longer catheter. We need to make sure that we're measuring our guide wire appropriately. Now, in this particular case, I'm just going to feed my wire into my catheter. If I can get it in, hang on a tick, sorry. So when we insert a catheter normally, we want to have a good amount of real estate in the vessel so that we can advance our dilator and our catheter. What I really want to do is, rather than confuse everybody about going backwards and forwards, what we want to do is we want to bring the J-tip into the end of the catheter just so that the catheter tip or the wire is exposed just at the end. And then we measure to the back of the hub. Now this is where we're going to put our alligator clip. So if I pull this out, and we have to do this before we insert the catheter, because we need to know that once the catheter is in the vessel by at least 3/4 of the length of the catheter, we're going to pull this wire back so that the tip is just entering or just at the end of the catheter hub here. So as you can see on this wire, there's the 30 centimeter mark you can see, but our actual measurement was back here at 32 centimeters. So when I put the alligator clip on here, you can see that my catheter tip or my wire is going to be just at the end. And this allows us to then to be able to insert the catheter and the wire and monitor our P wave at the same time. So measuring the guide wire against the overall catheter length is a very important strategy that needs to be done before the catheter is inserted. We're going to insert the catheter using a Seldinger technique, which is an over-the-wire technique, obviously, as per the manufacturer's and facility policy. And we want to ensure that at least a minimum of 3/4 of the catheter is in the vessel before we start manipulating the wire and attaching our alligator clip. And you can see from this image on the right-hand side of the screen, the alligator clip is going right behind the distal hub of the catheter. So we retract the catheter, and this is a better close-up photo that you can see where the end of the J-wire tip is actually just sitting right at the end of the catheter. If that was extended further past that and the J-loop was outside, our catheter tip may be up to maybe 1 or 2 centimeters, possibly too short if there's too much wire advanced out of the end of the catheter. So once we have achieved this and we put our alligator clip on, we're going to advance the catheter and wire as one unit until the P wave gets larger. We confirm our negative P wave deflection and then retract the catheter back until we get a maximum P wave. The catheter tip will now be at the CAJ. We can then stabilize the catheter, remove the guide wire, secure and attach any needle-free access devices and flush the device so that it's ready for use. So that's essentially the guide wire technique in a nutshell. The other technique, which is hang on, let me just go to this. So as I mentioned before, the distal lumen extension set for, some devices 10 centimeters. You need to check what products that you have that you use in your facility regarding the lumen extension sets, because that difference needs to be made up in the actual measured guide wire length. The table below really just gives you an example from the Arrow CVCs, stating that if you do have a 16 centimeter catheter, the alligator clip's going to go on at the 27 centimeter mark. If it's a 20 centimeter catheter, at the 32 centimeter mark, or if it's a 30 centimeter catheter, at the 40 centimeter mark. But don't just take my word for it. Measure it yourself. That's a very important strategy that every clinician will need to do when they're utilizing a guide wire technique, and is making sure that they've got an accurate measurement of the wire. So using the ECG adapter with CICCs. This technique can also be used on PICCs when a metal stylet is not available or not required. And one of the examples of this, we'll go into this in a minute, is that this technique can be used for all types of central catheters that are placed either using a Seldinger technique or a modified Seldinger technique. It can be used with central catheters that may have a distally integrated valve, and it can be used with tunneled catheters. The thing is that what this is doing is it's providing a continuous column of saline within the catheter's lumen to maintain conductivity. And what we see here is the ECG adapter. As you can see, it's got a Lua connection. It screws on to the distal lumen of the catheter. It actually does have a Lua cap on the end, so you can actually connect a syringe to it to be able to flush the saline in. So when I attach that to the catheter, all I'm going to do is screw this onto the end of the distal lumen, and I'm just going to pre-flush my catheter. As you can see, oops, bit of water, bit of saline. But what that's doing is it's priming my lumen extension so that it creates an electrical conductivity circuit so that when my alligator clip goes on, which I have one just here, I'm just going to attach that to the top here, and that completes my circuit. So now I'm monitoring intercavitary ECG using a column of saline from the tip of my catheter. The guide wire has been removed. So just to run through the steps for this technique, we're going to attach our ECG adapter to the distal lumen. We're going to insert our catheter as per manufacturer's guidelines and facility policy. That's always important. You can actually pass the guide wire through the ECG adapter before you attach the saline column if needed, or you can wait to attach it after the guide wire has been removed. So we're going to place, once again, the majority of the length of the catheter into the vessel, because we're still under intraprocedural sterile technique, so we can manipulate the catheter relatively easily backwards and forwards should we need to. We're going to create our circuit by attaching the alligator clip to the top of the ECG adapter, and then pick up our ECG trace and look for the changing or increasing P wave size as we advance towards the SA node. Once we get that negative deflection, it's confirmed that our catheter tip is once again past the SA node. We retract the catheter until we get maximal P wave, and the catheter will then again be confirmed at the CAJ. This process has obviously less steps in it than the guide wire technique. There's less amount of measuring. It's probably a lot simpler to use. When you think about it, you've only got really one piece that you're attaching onto the distal lumen after you've removed the guide wire, and then manipulate the catheter into the correct location. Obviously, the catheter will need to be secured after that, the ECG adapter removed, and put your needle-free device and flush and prepare it ready for use. So some of the things about laterality, meaning left or right side. For a right-sided insertion, obviously P wave amplitude continues to increase as the catheter is advanced towards the right atrium, or certainly towards the cavoatrial junction, and the P wave will be more likely to appear peaked. When the catheter enters the right atrium, P wave amplitude can become biphasic and then also appear to possibly have a P wave overshoot. However, the characteristics of a biphasic P wave have been reported not to be visualized in a fair amount of patients. A peaked P wave may appear earlier when approaching from the left-hand side of the patient because of the reflection of the pericardial reflection or stimulus of the lateral wall of the heart and the SVC. So there are some considerations to look at that you may see when approaching the patient from both the right or the left-hand side. So the big question, what are the procedural benefits? Well, one of the big things, and it came up in a poll question, is the reduction of chest X-ray use. We all know that chest X-rays are widely used for a number of reasons, diagnostic processes. But if we can reduce the amount of exposure and procedures that patients have around chest X-rays, that provides much greater efficiency, it provides cost savings, and it's less disruptive to patient care. So the use of intercavitary ECG really does provide a much more time efficient and offer system-wide efficiencies, not just at a department level, but at a facility level as well. And for those of you that have cleared your devices by using tip navigation and tip location, using intercavitary ECG, and have eliminated the need for X-ray, that's fantastic. We just need to be able to continue to move the needle forward so that we're seeing more of this and it become almost the next standard of care. That's what our aim would be fantastic to achieve. One of the other aspects that's really important is that we need to also be able to eliminate X-ray because we're trying to eliminate pneumothorax or certainly diagnose pneumothorax. And this is where ultrasound plays a very important role. And ultrasound can be used to assess the presence of pleural movement. And for those of you who have heard me speak on receiver, sliding lung is an essential component of patient assessment, both in the pre, intra-procedural and post-procedural phase of device insertion, particularly around CICCs. So we can assess for pneumothorax with ultrasound. We can use intercavitary ECG for tip positioning, and the combination of the two together, we can eliminate chest X-rays. We have our last polling question, so I'll hand this back to Judy and Blake for just a second.
Awesome. Thanks, Tim.
No problem.
Let's see here. Poll number 4. I'm going to launch this one. So what tools do you require to eliminate X-ray when using ECG tip confirmation? Just about 50% said policy. 30% said equipment for the procedure. 12% said training, and 9% said scope of practice guidance.
Yep.
And we've gotten some other responses that it should be all of the above. So.
Yes.
Well, that's true, but that's interesting because it's very much aligned with what a lot of clinicians ask about, and policy is probably one of the most important things to have established prior to starting any new procedure. Okay, I'm going to move along because I know that we're getting close to time. So cost benefits. There's been a lot of publications around cost benefits of using ECG for positioning of CVADs. The majority of papers have been around PICs, but one of the important aspects is to consider is that a PIC is still a centrally placed device. The tip is in a central location. So many of these costs, the cost benefits can actually be paralleled across to CICCs as well. And, you know, these benefits will definitely reflect positively. And there's been a number of publications more recently around tunnel catheters and certainly tunnel ports, dialysis catheters, and obviously some in our acute CVC or CICC patient population as well. There's also the benefits of allowing and using ECG to help reposition catheters that have become malpositioned. And there's been a number of recent publications around the use of intercavitary ECG to help correct or diagnose or, you know, reposition malpositioned catheters. And this can significantly save time and resources when you have something such as a simple adapter that can be attached onto the device and get an immediate response around what is the P wave amplitude, where is the catheter lying, etc., etc. So there's a number of techniques that can be employed in conjunction to assist this as well. And these benefits will be passed on not just departmentally, but across the facility as well. One of the things that I really enjoy about intercavitary ECG is that it's these 3 words. It's accurate, it's effective, and it's safe. And a lot of this is supported by the clinical evidence that's been published. There's over 100 and something articles, probably over 125 articles that have been published in the last 10 years around ECG for accurate central catheter tip positioning. A lot of it has come from Europe, but there are still many places around the world, as I mentioned earlier, that are publishing their outcomes with the use of ECG, and it's certainly getting a lot more attention. And these publications across a variety of patient populations and diverse clinical specialties, from critical care, nephrology, anesthesia, neurosurgery, oncology, a great variety of different areas that are benefiting from the use of intercavitary ECG for accuracy of tip position. there are quite a few publications, certainly that have come out in the last, say, 3 to 5 years with acute and tunneled hemodialysis catheters as well. So dialysis catheters are not missing out on the benefits of intercavitary ECG either. Are there any limitations to the use of ECG? Well, that might raise a couple of questions. A lot of people say, what about patients with AF? We'll get to that in a second. But conventional intercavitary ECG has very few limitations because the majority of it is based on the interpretation of the P-wave morphology. And while there are several conditions where P-wave morphology may be non-existent or there's an absence of a P-wave, there have been a number of publications that have come out recently, the most recent from Maria Calabrese in Italy, where she published a very good study on the use of intercavitary ECG in patients with atrial fibrillation. So there have been a few studies that have come out in regards to the use of ECG with AF, and it does show very good outcomes. Obviously, one of the questions around is pacemakers as well, because obviously there's a very faulty electrical rhythm that's underlying, that's being overridden by an internal pacemaker or an IED. So any pacemakers need to be checked with ECG and may still require the use of a chest X-ray. I'd like to hear any experience around pacemakers and the use of intercavitary ECG or see some papers on it. I haven't seen a lot, but I'm sure Dr. Pittarudi might have a position on that as well. It'd be interesting to hear from him at maybe one point. So I know we got to time and we're right on 6 o'clock now for us on Eastern time. Just to go through a conclusion and summarize everything, intercavitary ECG is safe for everybody, both patients and clinicians. It's effective. It has a higher degree of accuracy for optimizing catheter tips. It allows for procedurally efficient and faster turnaround for the use of the device, especially when we use and incorporate ultrasound and sliding lung to be able to eliminate pneumothorax at the same time. And we can do that both intraprocedurally and post-procedurally as well. So we can use ultrasound to assess multiple instances for pneumothorax if we need to. There's a lot lower radiation exposure. When we look at ECG and ultrasound, they actually don't have any radiation exposure. So you're taking all radiation exposure away by using ultrasound and intercavitary ECG. But one of the greatest things is that it can be used in any setting. So whether you work in an ICU or an OR or your vascular access team that places devices at the bedside, or even if you're a mobile team, intercavitary ECG has significant benefits across a number of these specialty settings and where clinicians are placing these devices. And with the technology that's available to us today, certainly being very reasonable in cost, it allows us to be a lot more accurate with our tip location and optimizing our catheter positions. So we always like to say that we have a call to action in regards to clinical practice changes. And I think one of the big things that we really need to see here, and that poll that Judy and Blake put up before really highlighted this, is that to really get a position around using intercavitary ECG to eliminate chest X-rays and optimize tip position, a policy is required and a policy and procedure is required, and documentation, clear documentation with lines of responsibility. The use of an ultrasound machine and an ECG monitor, and the use of an ECG adapter or a cable or an alligator clip style cable that can attach to the adapter to confirm intercavitary ECG conductivity. But also the biggest thing is the desire for the clinician to optimize catheter tip location, improve patient safety, and increase clinical outcomes and efficiencies. And on that note, this webinar has come to a close, and I'd like to say thank you all for joining me this afternoon or this morning or this evening, depending on where you are in the world.
Tim, that was great. Thank you so much.
Let's see here. Let's start with some questions and answers. How can you eliminate x-rays using ECG tip confirmation with patients with AFib or A-flutter?
How can you eliminate chest x-ray? Well, there's, as I mentioned in one of the last few slides, there's actually been a couple of publications around the use of intercavitary ECG with patients with atrial fibrillation, and you can still accurately position catheters. I think it depends a lot on what technology you have available. You know, I can't say that I'm an expert in every single piece of ECG technology that's currently available on the market at the moment, but I think, you know, the investigation of, you know, reading the clinical publications around the use of ECG with patients with atrial fibrillation, and really just if you do come across patients that have AF and you're asked to place a device, then, you know, it's really, you want to try and collect some data on it and form your own opinions whether it works or not. If, you know, the gold standard is still a chest x-ray, and if you're unsure that you can't verify tip location, then you would always fall back to the gold standard of getting a chest x-ray to optimize your tip, to verify your tip position. So I think a lot of it really would come down to, you know, read the research and see if it pertains to you, and make sure that your technology is sensitive enough to be able to to monitor that P-wave morphology fairly closely. I think one of the big things with ECG machines is that then you really need to be able to have the ability to slow the rhythm down, and you can, some ECG machines allow you to be able to slow the rate by half or 2.5 down to 5, you know, centimeters per second and things like that. So you can actually slow the rate to actually get a more accurate view of what waves you're actually looking at. So read the research and, you know, talk to the manufacturers of the technology that you use and find out their position statements. The other thing is, you know, also check the IFU, the instructions for use of the technology that you're using.
So another question for you, Tim. What, if any, disadvantage does parallax and patient positioning present when chest x-ray to verify tip position? So position being either we're going to be have the patient flat, have the arm in, out, up, down. That changes tip position, taking a deep breath, so to speak.
Well, you can certainly monitor that with ECG, and that will show you just how far the catheter is actually moving backwards and forwards. I haven't experimented doing that at all, manipulating the patient's arm, you know, abducting, adducting, and changing the position with ECG. I'm sure there are a number of clinicians out there that have done this before. They probably may have better answers than I have. But certainly, you know, we do know, and there is clear documentation that catheter tips can actually move, you know, quite a few centimeters with movement, certainly adduction or abduction of the arm. We have to be able to compensate for that. And I certainly, you know, agree that if we have the catheter that's placed appropriately, one of the great things that most of our patients are going to do, they're not going to walk around like this. So, while most of us walk around, or this, like even though in the clinical setting, you know, as in the inpatient setting, we do obviously manipulate those, they're only for relatively short periods. We don't leave patients in those positions for long periods of time. So small movements backwards and forwards where the catheter tip may move during patient positioning and things like that, I think they're you know, they're readily accepted that you know, it comes with the territory. But certainly, you know, if a catheter is placed too deep, then there is certainly greater risk of arrhythmia and, you know, any additional arrhythmia-related complications. And, you know, we need to be prepared for that. So, you know, using ECG to really optimize our tip position, you know, even distal third, you know, at the cavo-atrial junction, it's still optimizing our catheter. So patient positioning may affect that. We just have to be prepared for it and, you know, plan ahead. I always say, always be prepared more than anything else.
Like a Boy Scout.
I wasn't going to say that, but yes.
There you go. There you go. All right. We have lots of questions, so we're going to try to blow right through a bunch of them for you.
That's a good one. What do you think about trimming a catheter? When is the right time to do that? Before before you start the procedure, when you have your measurement, or maybe after you've confirmed your correct depth? What are your thoughts, Tim?
I guess that's more around PICCs, because obviously we don't trim centrally inserted central catheters, which is really what this presentation is about. I guess, I can put my personal hat on here for a minute. I'm not a big fan of trimming catheters because of the increased risk of, fibroblastic tips. But if you are forced to trim a catheter, you want to do it in a period where you've got an accurate measurement that's already been taken. And quite often, that means that the catheter has been placed to determine what the correct ECG is, because the catheter is always being trimmed distally, not proximally. So it does make it a bit of a tricky situation. This is where the use of one of these becomes very handy. And I still believe in pre-measurement with a tape to actually give us a good estimate, because there's a number of different ways that we can measure our patients and get certainly a relatively close catheter measurement. But the last thing that we want to do is trim our catheter too short, and then when we're advancing it, we don't get that negative deflection and we're already hubbed. That is problematic, and I think a lot of it really comes down to experience, the frequency of actually performing the procedure and things like that. As in the timing of when you trim the catheter, I think that's best left to the clinician to make the decision, because they're the one that's actually performing the procedure. I think there's a lot of very smart clinicians out there, and they make the best decision on when they need to decide to trim the patient. I'm sort of skirting around that one a little bit, because I think it's subjective, and everybody, has a different perspective on where they want to actually look at trimming the device, if they're needing to do so. I try not to trim the device if possible, but that's obviously around PICCs. But certainly with central catheters, there's no need to trim. So choosing the right length catheter in that regard is the most important strategy.
I share your opinion on that, Tim. Not that it matters, but I do.
It does matter. Everybody's entitled to opinion.
Opinions. So we have Jocelyn, our friend Joss. Canada's coming to the talk right now. She wants to know, can you speak to the unnecessary requirement of navigation when using technology? It is a nice to have, not absolutely necessary with ECG technology. Joss, I'm not sure if I did you justice here. I might just open up your mic and have you talk.
That's fine. I think I get what Jocelyn's saying, is that if you're using intercavitary ECG, do you need navigation? I guess it depends on the device you're using. As I said during the presentation, navigation is very useful for PICCs, obviously, because it's a longer catheter. It has a longer pathway to be able to get to the correct destination. With centrally inserted central catheters, you're looking at anywhere between, say, 16 to 25, 30 centimeters max of pathway that the catheter is going to take. And because the technique is sort of optimized with the use of Seldinger technique, the catheter is actually passing over the wire. So we're getting the majority of the catheter placed into the vessel early. Now, I hope I'm not off course with this answer for your question, Jocelyn. But like, for example, with the use of the ECG adapter, I did say during the presentation that PICCs without a metal stylet in them, you can actually use a column of saline method to accurately position your catheter. Now, because navigation helps you getting around the curves before you get into the central circulation, that's where the problem may lie, because you're not seeing the change in the P wave amplitude just there until you get closer to the SVC. If I've missed the point on answering this question, maybe we can talk about it offline, but that's how I understood your question. Is that correct? Maybe she can type into the chat window.
Yeah, either that or I'll just open her mic here in a second and we'll have her talk to us.
Okay.
Is there a difference between a power injectable catheter / line and an MRI CT conditional catheter? And is it a must have or nice to have?
Is there a difference between a power injectable catheter and a, what was it, MRI?
MRI CT conditional catheter, which I've not heard of. So
I can't say I've ever heard of that either.
okay, good. I thought I was missing something. So sorry, Maya. We'll type in another question and I'll try to get a better answer for you.
If the original poster of the question could maybe provide a little bit more information of
Exactly
what the differences are, that might help us be able to answer that question. I'd love to be able to answer every question, but I've not heard of an MRI CT conditional catheter. I've always been familiar with power injection or pressure injectable catheter.
Right. And if that is your question, is it a nice to have or a must have?
What, for pressure injection? I think obviously there are going to be instances where patients don't need a pressure injectable catheter, but with the amount of diagnostic imaging that's being performed in the current environment of today's healthcare settings, you know, patients go to CT, MRI on a fairly frequent basis, where power injection is required to inject contrast. And, you know, from a safety aspect, I think that's one of the most important things. You know, you'd never want to power inject through a non-pressure injectable device. And so certainly, you know, I think that what we'll see maybe in the next few years, I can't, you know, I'm not looking into a crystal ball or anything like that, but, you know, I think power injectable devices provide a much higher degree to the element of safety when it comes to pressure injection procedures. So while for some clinicians it might be a nice to have, I think we're going to move from a nice to have to being, this will probably become a more default setting for the type of devices that are being placed.
More than likely, especially with skew reduction and a lot of the other things going on in hospitals, the likelihood is you're going to have
Absolutely. If you were the clinician and you were asked to place a device on a patient and you had a non-pressure injectable device on this side and a pressure injectable device, you know.
And the delta in price has really come down. It used to be there was a delta, and now there's not much.
No, that's right. But if you were even just from the clinical perspective, let's eliminate the cost perspective for a minute. If you had two different, you know, the same catheter, but one was pressure injectable and the other wasn't, sitting beside each other on the shelf, which one would you choose? You know, unfortunately, we can't predict when patients are going to go and have imaging scans. So why not be prepared to say that, well, if I've got a patient that I'm asked to put a long-term vascular device in, there's a very likely chance that they're going to have some form, at least one, you know, pressure injectable procedure at some stage during their stay in a hospital, particularly if they're, you know, relatively unwell or a critically ill patient. That comes, you know, that just comes with the territory.
Right.
You know, and a lot of this is transition. You know, we've seen a lot of movement, you know, since the early days of when PICCs, you know, came out and they were silicone catheters. Well, you know, silicone catheters are, you know, certainly much less frequently used in the clinical setting these days because of pressure injection, or even hand injection for that matter, and the damage that can actually occur from, you know, overzealous use of a plunger in a syringe. So I would say that, you know, a PICC that has a power rating of, you know, 325 pounds per square inch is a far safer, it's a far safer bet if you're going to be placing a device where there may be the use of contrast injection.
Thanks.
So if we're getting ton of artifact on our ECG, making it difficult to assess the P wave. What is the best way to help reduce that artifact when it comes to looking at ECG tip confirmation?
Well, that's a rather open-ended question, actually. It depends on the environment that you're actually placing the devices where you are getting the artifact. If it's in the general ward areas, quite often they're not cardiac protected areas, and so the electrical system is rather like a standard wall outlet as opposed to a more protected system. So when you go into like critical care units, coronary care, cardiovascular, ICU, they all have what they call cardiac protected circuits. And these have a much lesser influence on, electrical circuitry and electronics than in the general ward areas. Now, I'm not saying that that's the sole reason, why there may be artifact. The patient could be shivering and it looks like, artifact. The patient could be cold. So, there are a number of things. Is there a filter on the power line that connects to the wall outlet? All these sorts of things can influence, electrical signals. Are the cables old? If they've been wiped over with alcohol for many, many years, this degrades the quality of the cable, and it can also induce, particularly if there's little fractures in the line, it can actually induce more artifact because the actual cabling has been damaged. One of the other things around electrical interference are watches, electronic devices like Apple Watches and stuff like that. So removing all of that material from, a 6-foot radius around the patient is going to be an important strategy as well. I'm not an engineer on electromagnetic fields, but I certainly, have worked with many electrical items over the years and even been electrocuted myself, at one stage, but not in a healthcare environment, just for clarity on that issue. But I think the thing is that if we can minimize any risk of EMF around the procedural area, that will help reduce artifact. But, check the patient as well. If they're cold and they're in a bed and they've only got one blanket on and they're shivering a little bit, that's going to cause artifact anyway, just from that micro muscle movement. So, checking the environment and checking our patient are going to be, essential components of part of our assessment process as well.
So Tim, I know neonates are not your bread and butter, but I'm going to ask you a question. And those that are here, like Connie and some of our other neonatal friends here, I think Trisha's still there, probably drinking coffee. But any evidence to show PICC with Guidewire will increase the chance of perforation on neonatals, bedside PICC insertion? So if you're not...
Look, honestly, I can't answer that question, but Dr. Pittarudi probably could. Right. I don't know if Mauro is on this call. I suspect he wouldn't be because it's midnight in Italy at the moment. But right. I would have to defer that answer.
Connie says no evidence.
Yeah, that doesn't surprise me.
Right.
But I would defer that to my esteemed colleagues that specialize in neonatal and pediatric care, particularly around vascular access. I'd rather pass that on to the experts.
And Connie is on right now, and she says the NAN guideline supports the use. And it's awesome. So there we have it. Good.
Mm-hmm. It doesn't surprise me because I know that Mauro uses, he uses intercavitary ECG to place his devices in his neonatal patient population. But when it comes to the Guidewire aspect, I'm unsure and I couldn't make comment on that.
Perfect. Thank you so much. We're getting a bunch of new questions still, so we're going to try to go through.
Here's a good question. What's the reliability of the use of ECG on patients with a pacemaker or AICD? Have you run into any issues about that? I know you did speak about that earlier.
Yeah, no, there's not a lot of research around intercavitary ECG and pacemakers. I don't want to say that it can't be used, but I don't want to say that it can be used. I'd have to really plead professional fence sitting on this particular topic, because I'm not 100% sure, and I wouldn't want to give the wrong answer or a false positive. But there's, you know, a literature search would certainly show up if there was any information. In my literature reviews that I've done on ECG, and I've done a lot, I've never seen anything on pacemakers. There may be something out there. It might be in a foreign language. It might be published in Spanish or German, or, you know, in another country. But I've not come across anything in my literature searches that I've done on this topic.
This is a great question, and I'm sure has frustration from other people in the group. We obtain our ECG confirmation, and then later in the admission, after the x-ray's read, we're told to pull it back X amount of centimeters. This is frustrating. And is there any advice from you?
So is the clinician using ECG to place their device? But
they are, and they've got their confirmation. I mean, my thought is partner up and educate your radiologists as well.
Absolutely. When you implement new strategies like using ECG for tip positioning, whether it be for CICCs or whether it be for PICCs, we need to make sure that we're educating everybody on board, that they're aware of the changes, because catheter tips will look, and particularly, well, let me finish that sentence. Catheter tips will look deeper than what they used to be, because the thing is that radiologists have probably been reporting catheter tips that have been actually too proximal. And what they thought was acceptable is now, when they look at the x-ray, it's 5 centimeters deeper, and they're thinking, oh, that catheter's too deep. A lot of that really is bringing those departments together and going through the information and saying, listen, we're using new technology that optimizes our catheter tip position. You are going to start seeing x-rays. If you're still doing it and you haven't eliminated it, we're going to start seeing x-rays where the catheter is going to be deeper than what you're used to seeing. And I think it's really just getting everybody together to have a much more collaborative understanding of the process, and using that opportunity to really educate so that everybody's on board, because I know that would be a frustrating aspect, that you know that you've placed the device in the optimal position, and then the radiologist reporting says, no, it needs to be pulled back, 4 centimeters. Rewind to the slide that I talked about sensitivity and specificity. And this is where the difference lies between the use of ECG and ultrasound as compared to a chest x-ray. There's much more variance and a far lower degree of sensitivity and specificity around a chest x-ray. As I said, it's around 65, 68%, whereas ECG and ultrasound is greater than 95, 96%. So, we're trusting our instincts on this, and the evidence speaks to that higher degree of sensitivity. We know that, and this has been well published in many ultrasound critical care journals around ultrasound in its degree of accuracy as far as sensitivity and specificity. My point being from earlier is that if I gave the same chest x-ray to 5 different radiologists, they would all report it slightly differently. And that's where the problem lies, is that there's too much variance in the reporting structure. Now, I'm not saying that it's their fault, it's what they're seeing, but bringing them into the process when you're implementing a strategy like using ECG to position CVCs or PICCs, they need to be brought in on that as well, so that they understand that what they're seeing is not abnormal. Right.
Okay, so we're gonna try to get through all the 17 questions or more that we still have. So we're gonna try to keep our answers brief, not to ever try to break your spirit, my friend.
I have to have a drink, sorry.
Yes, please. Yes, please. Okay, so let's go for one from, again, my friend Joss. How well does ECG determine tip location for a left-sided SVC?
It's no different.
Perfect. Thank you so much. Blake, you're up. We're going to try to get through this.
That was fast. Way to be efficient.
I know. Well, I ask and it's done.
That's my interpretation. I know that, I don't know if Evan's on the call or Nick Mifflin from my old facility back home in Sydney, but they published an article on left-sided SVC a couple of years ago. It'd be interesting to hear their perspective because they use ECG for their devices and whether there was any change in P-wave morphology in left-sided SVC. But if you think about the electrical conductivity pathway, technically, and I'm saying technically, it shouldn't be any different.
Very good. And I'm not seeing anything to the contrary in our comment. So, okay, Blake, you're up.
Let's see. Oh, there's a follow-up question to that one, which is also, sorry, regarding left-sided placement with bilateral SVC and no bridging vein, does it determine left-sided SVC? Interesting question.
Yeah, I have to answer that with a, I'm not sure.
Yeah.
Very good. Good answer.
That's with like a dual connectivity. Is that what they were saying?
Well, if you have if you have bilateral SVCs, so you have a left and a right. I mean, we're getting into the lowest percentages of normal.
Yeah, like that's something. Like I've been a vascular access specialist for almost 30 years, and I've only seen left SVC twice in 10,000 catheters. So if someone's seeing that, they need to buy a lottery ticket.
Yeah.
Right. I've seen one.
Yeah.
Alrighty.
Yeah.
Guidewire for our direction from MedComp wire says it must be inside the catheter to less than 1 centimeter from the tip. Cannot be outside of the catheter due to vessel injury. Is this, first of all, is this incorrect? If it's in the IFU, we're probably not going to touch that. We have to flush. We are using saline method through the wire. So,
is that the same question or a different question?
same sentence.
So
Well,
they're saying that they retract the catheter's guide wire back 1 centimeter. Is this for a PEEK or a CVC?
I'm going to say it's for, it doesn't say, but
Okay.
if the IFU says to keep the wire inside the catheter,
Then you should follow the IFU.
you're in a legal loophole there. You
Yeah.
don't go against an IFU.
You should follow, well, absolutely is recommending the, following the manufacturer's IFU, because if you don't, it opens up a world of pain if there's a problem.
World of hurt. Okay. You're saying that we can take those elevations from the atrial waves are what we're looking for. Do you see them, but policy is with the P wave?
Yep.
You're saying yes, Mr. Blake?
I would say, if your policy says, and that's really, we talked about this, we pulled it. If you have a policy that says you need the P wave, an FDA approval for atrial fibrillation, again, what are we doing? We're really eliminating the need for extra x-rays. You kind of, that you're in the right spot, but your policy, the approval, FDA, whatever, is saying it's only approved for P wave, maximal and negative amplitude, then that's all you're gonna get to go with. You'll need that x-ray.
Well, you will. And, that's a safety aspect as well. And, we always want to promote patient safety. And while we may have to get an x-ray in a particular patient population where the P wave is not visible or it's not seen easily because of, some form of atrial arrhythmia, the frequency of these patients is probably relatively low. The majority of patients, unless you worked in an AF clinic that put PICs in every day, that'd be a different story. But, from a safety element, I believe that the number of patients that you would see with AF where you would be required to get an x-ray would probably be on the much lower side than your standard regular patient that has a normal sinus rhythm or, a normal P wave morphology. So it's better to err on the side of precaution and follow the rules than go off label.
True. Cuboatrial junction tip location. A patient is having arrhythmias when lying on their side. Thoughts?
Turn them
Pull it back a skosh.
Pull it back a scotch. Must be someone from the northeast.
Back over.
And sadly, I'm a San Diegan, born and raised. But
I know
just a
what
touch.
The words of John Bell, that would be janky.
Yeah,
That's me. I'm full of that.
I know what a
Like-
step is. Well, I think, look, it's patient positional. So, you know, if you move the patient out of that position, does that arrhythmia resolve? Like I said, you know, it's the same thing if you abduct or adduct the arms. If the patient, you know, we don't walk around like this all the time, or like this, where, you know, the catheter tip is manipulated. I guess if it's problematic and the patient is symptomatic, then, you know, it might be worth pulling the catheter back a centimetre or so.
That's a skosh.
Well, that's a scope. Yeah, exactly. It's a small
A dram, or, you know.
But, you know, I think a lot of it would come back to clinical assessment of the patient,
Right.
particularly when it comes to positioning. You know, how long is the patient, you know, staying in that one position where they may be having arrhythmias? You know, is there another position that they can be put into or positioned in to help reduce that risk that they have, you know, a slight arrhythmia? But we want
Are they having a PVC or are they going into VTAC?
There's a huge difference between those
Right.
two, absolutely. And, you know, one of those is generally non-life threatening and the other is the other end of the scale. It can be.
Right.
So I think, you know, wide berth is important, but, you know, patient safety is always paramount.
Right. And also the left and right sided placement plays a bit, you know, we can't get it too short. There's a lot to do with that
Of
one.
course, absolutely.
More than just pulling it back a skosh.
That's what makes our specialty very interesting.
So much fun.
Here's a question. With repositioning catheters and using ECG tip confirmation to do so, are we talking about advancing the catheter after insertion or just withdrawing it a centimeter or a skosh?
Well, one, we should never advance the catheter after it's been placed. So that becomes an infection risk. I guess the big thing is that how do we determine that the catheter was malpositioned? You know, if it's up in the IJ and you flush the device and the patient can hear, you know, the saline bruit as it passes, you know, the ear canal in the IJ, then you know that it's definitely in a bad position. I don't think ECG would fix a catheter that was that malpositioned. But on the other hand, if the catheter, you know, patient had a routine chest X-ray during their hospital stay and it showed the catheter tip had sort of looped up on itself in the, you know, upper superior vena cava, you know, a high flow flush technique might allow repositioning of the catheter, and we could use ECG to confirm the P-wave morphology after that had been performed. So, you know, there's a couple of things that you could possibly do. I certainly would not advocate, you know, advancing the catheter after it had been manipulated because of the infectious risk. If you wanted to retract the catheter for any particular, unless there was a clinical reason to actually retract the catheter, then, you know, that may be on order. But a lot of the times the catheter was positioned correctly on the initial insertion. And so the inserted catheter length still remains the same unless there had been a change. So the tip should actually go back to its original location. That's the idea around that anyway.
Perfect. So Pat Gaynor says, thank you for a great presentation. I second that. 2 questions. What was the reference, please, regarding the rates of right atrium thrombosis complication? And could you please provide some more details regarding the cephalic as a vein of choice for insertion?
Right atrial thrombus had a relatively low complication rate. I think it was less than, actually on the slide, it was 0%. A large right atrial thrombus can become a life-threatening situation, because if that dislodges and flows into the pulmonary artery, you have going to have pulmonary infarction almost immediately, and the patient is at risk of death. So, you know, a large atrial thrombus can be very problematic. While the reported evidence around the devices is probably relatively low, I haven't done a literature review on right atrial thrombus. That would need to be done. Good topic for a Java paper if anybody's out there interested in writing one, because that's more of the rarer complications that are seen. But just because it hasn't happened doesn't mean it won't happen. And we need to be prepared for that as well. So we can also use ultrasound and certainly echocardiography to keep an eye on any potential for thrombus that's in the atrium, because it can be seen relatively clearly on a substernal view with an ultrasound.
Thank you, thank you.
What was the second half of that question again, Judy?
Oh, I cleared it. It was, gosh, I'll have to go back and.
It's all right. Because I was answering the right atrial thrombus, but I knew there was a part 2 to it.
I will get that and get you part 2 here. Oh, there we go. Details regarding the cephalic.
Oh, the cephalic vein. Not my favorite vessel of choice, I'm afraid. I did a presentation for AVA back in 2016, I think, on the dangers of a cephalic insertion, particularly around pressure injection. It is often a vessel that is chosen because it's very superficial, particularly in patients that have, a relatively large BMI, and a lot of it is because the vessel is large because they have a larger. These patients have a larger circulating blood volume. It's also very anterior and very superficial, which makes insertion very easy. But it's getting around the junction where the cephalic vein that actually joins into the axillary vein that it becomes more problematic. And also, there's...
They may have been talking about centrally inserted, because if you come up here to the cephalic, it's a nice little vein that pops that gets you a lot.
Oh, for a central line? I've never placed a central line in a cephalic vein. It's too small.
Okie dokie.
You put a 7 French in a cephalic vein. Yeah, the vessel on the arm might be this big, but where it goes around the corner up here is probably a lot smaller. So your catheter vessel ratio is going to be drastically different. And most acute CVCs are generally, 7 French. So I would not necessarily be using the cephalic, although they have been obviously used for tunnel catheters in the past before, but more around.
That's actually a good point. It could be a whole different spin-off webinar about talking about this big juicy cephalic in the upper arm. And then as it turns the corner and you put an ultrasound on it, it could safely hold a 3 French nicely.
It's a quarter of the size. Well, my presentation that I did for AVA is actually on my blog site as a video. And if clinicians want to go there and have a review of it, there's no audio. It's just the slide deck turned into a MP4, but they're most welcome to go and have a look at it. vascularaccess.com.au is my blog. And it's under the cephalic vein, choice or chance.
So where's the evidence and research on CVADs, CICCs and PICCs, tip placement into the upper RA? And how close are we to changing this?
CICCs and PICCs, well, I don't think there's a lot of evidence that discusses PICC tips in the right atrium. It's more about hemodialysis catheters than anything else. And the DOKI guidelines address that.
And I think there's a lot of places that have been addressing it where INS has upper RA. There's, alrighty.
For acute CVCs, we don't want to be in the right atrium. And certainly for some long-term catheters, like tunneled or implanted devices, sometimes these catheters are placed just at the entrance of the right atrium. But, going off the professional organisation recommendations and guidelines, although many of them say 1/3, distal 1/3 of the SVC, cavo-lateral junction or upper right atrium, I think it's more the upper right atrium is more frequently used amongst the hemodialysis patient populations than it is for our other catheters, our other central catheters.
True. Okay, guys, we're down to 5 questions. We're gonna get these and send you guys to dinner, hopefully.
How do you convince providers to trust your sliding lung results with ultrasound?
The facts speak for themselves. Really? As I mentioned in one of my slides, there's a much higher degree of sensitivity and specificity around ultrasound. And so it's much more accurate and it can pick up much smaller pneumothoraces that you can't see on a chest X-ray. So that sensitivity alone is going to speak volumes. And there's a lot of evidence around that. Daniel Lichtenstein is one of the authors that's done a lot of research around lung ultrasound pneumothoracy detection, particularly during invasive procedures around CVCs, a variety of things. Ultrasound gives so many benefits to the clinician from a diagnostic perspective, but also from a procedural aspect. And, you know, if you're trained well with ultrasound to do lung ultrasound, and certainly if you're performing receiver and you know what pleural function looks like, whether it's positive or negative, you know if there's a pneumothorax or not. Because remember, assessment for sliding lung, particularly during receiver, is done on the anterior aspect of the chest between the third and fourth rib, but it doesn't necessarily mean that you have to stop there. The good thing about ultrasound is that you've got a bottle of gel and you can slide that probe all around. Now, proper full lung assessment, if you work in the emergency department, is anterior, posterior, and lateral assessment of the lung. So you're not missing out any part. You're assessing the different lobes. You're looking at for pneumothorax that may be in an anterior or posterior, but also an apical or lower segment area as well. So you can really utilize the movement of your ultrasound to get a very good, accurate picture of what the pleural function of the lung is like. So with proper training and understanding of what you're looking for and what you're seeing, ultrasound is a very strong focal point to be able to use to eliminate or certainly monitor pleural function to look for pneumothorax and eliminate it.
Here's another question. Once you get your tip in the right place and you have your bullseye, how do you recommend it stays there, especially during the dressing changes, which we don't do as specialists? So I guess this is more about securement.
Yeah, well, dress it down under the chest.
Yeah.
And use a manufactured securement device. Consider gum mastic, consider tissue adhesive, but a manufactured securement device, either adhesive or sub-Q as well.
Well, I don't need to answer that now. Thanks, Judy.
All right, gotcha.
No, that's okay. Look, I think to add to what Judy just mentioned, education is so important here because, like you said, if you have a team that is not doing the care and maintenance phase while patients are having their devices dwell, making sure that clinicians understand that, you know, how to remove the securement device appropriately and properly without manipulating the catheter or causing any pistoning at the insertion site, which can lead, obviously, we all know, to device retraction. And that creates a more proximal catheter tip naturally. So a lot of that comes down to, you know, making sure that clinicians are educated well and properly and understand the ramifications of if they don't put as much effort into removing the dressing and the securement device properly, that catheter malposition will occur, and that can lead to more complications with the patients in the care and maintenance phase.
Perfect. We did that one. We use 3CG for tips, confirmation. A lot of times our max P wave goes well beyond the QRS without having any negative deflection. Any opinion on this?
Maybe you haven't gone down far enough.
There we go. Thank you.
The only reason why I'm saying that is because you'll only generally get a negative deflection once you've passed the SA node. So until you pass the SA node, when you get the negative deflection, if you're not getting there, that means your catheter might still be at the cavo-atrial junction and it hasn't gone down past the SA node to get that negative deflection. And that's what ECG is looking for, because that's part of the confirmation process to monitor the amplitude of the P wave. Yes, you're getting a maximum P, and it may be larger than the QRS, because that means you might be sitting on the superior aspect of the SA node. You know, another couple of millimeters could make the difference between flipping that max P wave or that peak P wave to a negative P wave, and then you pull it back. And that could be the difference of a scotch. You know, it might only be a few millimeters or a half a centimeter, but that's all it takes. And really, we are looking, part of the process is to make sure that we get that negative deflection, because that tells us that we've actually gone past the SA node. We don't want to go deep past the SA node. We just want to go past it a little bit and then retract the catheter to P max. And they're important. They're all important strategies as part of the confirmation process that clinicians need to go through when they're placing their devices with ECG.
with that, I think you answered two of the other questions that were on the board. So
Pretty impressive. You got a twofer.
touche.
That's great.
Let's see here. Looking for. Yeah, this is also very similar. I think that's kind of it.
I think you got it.
I think we did it.
Talking
Cleared
more
the
about
board.
Gothic rhythms. So strong work.
No, that's
Thank you
okay.
so much.
It's look, it's a pleasure. It's nice to be here, and thank you again to Ava for inviting me to come and speak today, and also thank you to Teleflex for sponsoring the session as well. I think it's really good. It's great to see that we had so many participants and lots of questions. Obviously, there are lots of clinicians out there that are using ECG with PICs, but we really want to move the needle forward and utilize this wonderful technology to be able to accurately position our centrally inserted central catheters as well.
Absolutely. Absolutely. So thank you for all you do. Everybody out there, stay safe. We appreciate you. And we hope to see you next week.
Absolutely.
Bye, everybody.
Thank you, Judy.